what are you going to talk about for fibroids? Because I think you hopefully have a lot of experience with fibroids, and there may not be much I will share, but there are some things that I think are going to hopefully change the way you practice in the upcoming few years as well. So let's get started with that. Uterine fibroids are common, and the issue with uterine fibroids, these are my disclosures, is that we need to find the ideal treatment so that we can hopefully move on. And there is a treatment, something called the selective progesterone receptor modulators. I understand it's not available in Kuwait, but has anybody had any experience with this medication? Nobody. So good. So it will be something new. And just to give you an example, I like my videos, so I will show that as well. This is a patient I was called in to help. My new colleague started and she said, I have a small myomectomy. Do you mind coming to help me do this case? And I said, sure. And when I showed up, this is what I saw. Oh, let's go back. So at the end of the day, it was, that's what it looked like. So not too bad, right? But I pulled out more fibroid. There's her ovary right there. And pulled out, wait for more, even more. And so I was not happy with her. And that was after our myomectomy. See how beautiful the uterus looks? Looks perfect, doesn't it? The issue is we love doing surgery, and there were 68 fibroids that we removed. Her uterine cavity was normal. That's the only reason I agreed to even stay in the room. And today she is doing very well, but obviously there's a risk of recurrence and amongst other things as well. The point is fibroids are common. The patients you see from around the world is a multicultural group. You know that there are definite differences based on ethnicity and background. And it is going to be one of those things that we cannot obviously cure, but we need to figure out a solution or at least a plan for it as well. So there is a difference in lifetime between a woman of, we call it African American in North America, obviously African women and Caucasian women. And at the end of the day, it's one of the main reasons for hysterectomy. So for those of you who enjoy doing a myomectomy, you haven't done enough yet, because they are very complicated and they can cause a lot of problems. When the women present, they present with one of three things: heavy bleeding, reproductive dysfunction, or mass effect. And many women in Africa and all around the world don't present with anything at all, and they walk around with heavy, big fibroids. But if they present with problems, we need to look at managing those problems as well. For those of you who are familiar with the Palm Coin World Health Organization approach to abnormal bleeding, which I really recommend for those learning, but also those who have learned and need to relearn, that this is a good way to look at things. And as we were talking about before with imaging, fibroid mapping is essential in order to determine what you're going to do for fertility. I don't think I'm wrong in saying that in this region, fertility preservation is a very important consideration, and saving the uterus, whatever the age is going to be very important. And we have many women over the age of 45 who are determined to have that baby, and that's where I learn all about the highly religious population that we have, because God will give them a baby even though they're 55 years old with the uterus. So at the end of the day, it is important. So I'm going to jump into what is the ideal therapy. Well, the ideal therapy would manage the signs and symptoms. They would offer a sustained reduction in the fibroid so that if you can shrink the fibroid, it would stay away forever, and of course save the uterus as well. In terms of the options, in terms of algorithms that we may see, you can access this article where we created an algorithm. If you type in my name, current medical opinion, and it gives you a simple approach in terms of different options. So I'm just going to walk you through a couple of things. If they're asymptomatic, leave them alone. If they want to get pregnant and they have symptoms, well then at that point, you need to think about either fertility enhancement or myomectomy. But see, I've added something here: pre-surgical medical treatment. And look what's new down here. Long-term medical treatment for fibroids in somebody who wants to get pregnancy. Is that possible? It is. And then what about fertility not desired? So they don't want to have fertility, but they want to preserve their uterus. You have lots of options. Look down here again. Long-term medical treatment for patients? That's crazy, but it isn't. And then, of course, those who want to have don't want to have uterus preserved, you can pre-treat them medically, do a hysterectomy, or what? Long-term medical treatment again. So there's something on the horizon that we got in 2013, which I'm going to go through with you. So in your options, you have your medical options, your interventional options, or your surgical options. You know about the surgical options. I'm not going to go too much into that. What we're going to do is focus on interventional and medical options. Is uterine artery embolization available in Kuwait? Yeah, so there you go. So it's one option. Gynecologist, depending on which side you're on, you either don't agree with it, you don't believe in it, or you've had good experience with it. I'm not going to get too much into that. I personally don't believe in MRI-guided focused ultrasound simply because of the cost, the amount of time and discomfort to the patient, but again, it is another option that is being thought of and discussed elsewhere. And again, surgical options you know, so I'm going to leave that in the interest of time. But for our medical options, we look at either controlling the symptom or targeting the fibroid itself. All of the focus we've always had is controlling the symptoms. I want to make their bleeding better. We use tranexamic acid quite a bit. We can use hormones. But what is this targeted therapy? So you can actually shrink the fibroid and target it. And I'd argue that GnRH analogs don't necessarily target fibroids because what do? Shut down everything. So yes, everything will shrink. But the issue is we finally have medical therapies that target the fibroid directly and cause a result that will result in a long-term shrinkage, and that is where this talk will go. So if you haven't heard of them, they're called SPERMs, not the best name, but they're selective progesterone receptor modulators. And when Dr. Work and I were studying for our Royal College exams back in London, Ontario, in Canada, we remember one paragraph, one line in Spiroff, which was the infertility book, and it said, fibroids are promoted or grow because of estrogen and other factors perhaps, but there was this line that I always remember saying, progesterone results in fibroid development and growth. Yet, we quickly forgot about that. We didn't think about that. And that is where this message goes. If progesterone results in fibroid growth and development, there's something else going on. We can target this treatment rather than just turning off all the estrogen and progesterone in your body by giving something like a GnRH analog. And in fact, progesterone acts in many, many places. I don't know if you know this, there was actually a study of IV progesterone in critical brain injury. So the brain was injured in these patients from trauma. They were being cooled. They were given IV progesterone. It was a study out of the US to see if they can help preserve the brain. At the end of the day, the results were somewhat positive. There's other things they can do that are better, but the progesterone in your body plays a role in the breast, in the uterus, and now we know in fibroids. Now, the interesting thing is that we knew this many, many years ago if you've been following any fibroid discussion. If you block progesterone, you will shrink fibroids. And there's a medication called mifepristone, which is not going to be available in the Middle East because the other use for that was, did you guys know what it was? Medical termination. Unfortunately, the politics and the other issues have resulted in this not becoming available for women to treat common gynecologic conditions. And it is a pure progesterone receptor antagonist. So what they did is they developed all these sperms, right? Not like SERMs, but sperms. And ulipristal acetate is the one in the middle, and there's a new one that's going to come out as well soon by Bayer. That has some agonist and some antagonistic activities. And in developing that, they were able to target the progesterone receptors at the fibroids without causing problems elsewhere, hopefully. We will find out in another few years. And at the end of the day, allow you to inhibit proliferation, induce apoptosis of these fibroid cells. So these sperms attach to the receptors. In some tissue, it attaches and it causes a positive effect. Some places it causes a negative effect depending on the end tissue that you're talking about. So at the breast, you don't want it to work, right? So it doesn't induce breast cancer. We know that with this medication. But in the uterus, it will result in an impact on that fibroid. So we're going to keep it simple. We've had it now for several years. For the fibroids, it directly inhibits the proliferation of the fibroids and actually causes cell death. We're not sure how. That's very confusing to us still. We're working on some of that information.
Excuse me, 5 minutes left.
Oh, thank you so much. At the endometrium, it actually stops bleeding immediately. And I think that is profound and very important. So you can control somebody's heavy menstrual bleeding as soon as you start this medication. And at the pituitary, it causes central inhibition, and we're not sure if it causes anovulation or not, but certainly it might work on all 3 levels. But this is very, very important. So there are a couple of, many studies now, but the 2 pivotal trials were in the New England Journal of Medicine, where they compared this medication to placebo and compared it to GnRH agonist. And the study designs were well done, and they looked at really heavy menstrual bleeding with uterine fibroids, and they gave everybody iron as well. Don't forget iron. And what they found, this is one of the key points, is that bleeding control within the first 7 days, you get that woman who's been bleeding and bleeding and bleeding every period, within 7 days, she has a huge reduction in bleeding that lasts for the treatment time. Treatment time generally right now is 3 continuous months. And then the other one against GnRH agonist showed the same, but see how GnRH agonist is the lower black line? It'll control your bleeding, but see how it takes up to 30 days, right? That first month after GnRH agonist is unpredictable. But with the SPRM, you get immediate control of bleeding. It's too good to be true, isn't it? I always say that. And at the end of the day, the other thing you notice, this is GnRH agonist. See how after a 3-month course of treatment, you wait, and see how this is fibroid shrinkage. The fibroids regrow. So initially you get 55% reduction in volume of the fibroid, but by the end you get only 17% because the fibroids regrow. You stop the medicine, the fibroids come back. But with UPA, you actually see that after you stop treatment, this is when we stop treatment, the fibroids are still small up to 38 weeks later. That's sustained reduction with no more medication. And so when you look at all the studies, there's been so many studies, Pearl 4 studies, you see here, after time, after 1 course, you give 3 months, you take a break, you get up to 50% reduction, you wait a bit, you give another course, 3 months, more shrinkage, you get cumulative shrinkage in this side. Whereas with GnRH, they regrow, and that's very, very important. So in summary of this medication will rapidly control bleeding. It will help reduce the volume of the fibroids by doing it quicker than GnRH agonist, and it has a very low side effect profile. So you don't get hot flashes as often, you don't get all the other things as well. So the thing you have to remember about this medication, because I've done a very quick summary, is that bleeding is well controlled in general, and that the fibroid size reduces quite significantly. There are some safety things that have been studied. Right now, we think it is very safe. That's why we only give it for 3 months, but we must have a withdrawal bleed to make sure the endometrium is okay. All the evidence says it does not cause hyperplasia or cancer. And so 1 course is good, but in the world now we are using multiple courses. So I have patients who are on the medical therapy now for 2 or 3 years, and they continue to cycle on it. Some try it for 2 cycles, they're happy. 6 months or a year later, they might come back and say, you know what, maybe I'll do another 3 months to see if it works. Now, in terms of limitations, not everybody will respond. The US data, and I was part of the research there, will be coming out soon. And in our African American population who have 30 fibroids or are overweight, it doesn't work as well, but still works well. Not as well as the thin European woman that they studied it in initially, but it still works. That's very important. There are questions about what it does for surgery and other things as well. In terms of pregnancies, my group with University of Toronto, University of Ottawa, we have the largest pregnancy group now. We have about 30 patients post-UPA with the results, but Professor Donay's group had presented the first 18. He loves showing this picture where he shows fibroids that are there. After treatment, they disappear, he says. They're gone. And then the patient has a baby, and then they come back with a normal-looking uterus. I haven't seen that effect, but he's had these reports as well. So The other issue when we do medical therapy, and this patient, we left her fibroid behind. I was going to do surgery after medical therapy, but she got pregnant. There are some things we have to worry about. And so this patient, here at C-section, I took out the baby through a fundal incision because the fibroid was in the way. And unfortunately, that fibroid that we were trying to manage conservatively popped out. And so at the end of the day, I think not every patient, is best to leave the fibroid behind. She actually did very well and wants another baby. But the point is, I think you all have experience with surgery. You will have questions when this medication comes out. You will try to figure out how to balance it. But the point is you will end up using it. So you will use it by preoperative optimization if you're a surgeon and you only want to do surgery, because the bleeding will stop immediately. They will be happy. The fibroids will get smaller to make your surgery easier. Some of you, and like myself, still might like Lupron, at least even one dose to decrease the blood flow to the uterus. So you can use combinations of both. You will control symptoms in those who don't want surgery and are happy. And potentially some patients will say, I'm so happy on it. You booked me for surgery. I'm going to cancel my surgery. I'm going to keep going on this medical therapy. So it's very, very important. And I'll leave you with the last video here in a patient who had 2 courses of UPA. She actually was a fellow from Saudi who was working in our hospital, and she was also very anxious. So we gave her 2 courses of UPA, brought her hemoglobin up to an excellent number, shrunk the fibroid, and then went ahead and did a nice laparoscopic myomectomy, let it heal, and 6 months later she was pregnant and is ready to have the baby as well. So at the end of the day, we have surgery, we have medicine. I hope I've been able to introduce you to a new approach that you may want to consider as we move on to the future. So I think I'll stop there. This video here. Yeah, good. Thank you.